Thank you, Ningwei, and good morning to everyone who are physically present here and who I believe are also on Zoom from elsewhere. It's a great pleasure to introduce Professor Magnus Nilsson. I actually don't need this, but I wrote down certain things which I wanted to highlight. He's a professor of surgery at the division and head of division of surgery at Cleantech, Karolinska Institute, and a senior consultant, mainly doing upper GI surgery, which you can see from the topic today. His interest is in gastric and esophageal cancers, but very interestingly, it's also in the minimally invasive surgical techniques in treating these conditions. I was also very intrigued to find that he is actually very interested in severe surgical complications. And I think his practice of esophageal surgery, for example, like my practice of pancreatic surgery, always gives you an opportunity to see these severe complications, unfortunately. But just to quote those of you who are well versed with writings of Atul Gawande, the difference, and I quote, the difference between the good and the great. Both good and the great fail equally, but the great salvage more. I think this is a great message for those of us who are involved in high-stake operations, whether it's transplants, whether it's colorectal, complex surgery, whether it is esophageal surgery. So if I could read out Professor Nilsson's, he's essentially president of the European Society for Diseases of the Esophagus, Swedish Society of Upper Abdominal Surgery, and a director at the International Society of Diseases of the Esophagus. He's a chairman of the Swedish National Registry for Gastric and Esophageal Cancer. He has been running randomized trials, leading them. A couple of trials which I do not know anything about, ESMO and NEEDS and NEO R1, R2, in which case, all of which probably you know more than I do. But again, I got memories when I read that he is also leading the EORTC trial. Many of us who do pancreatic surgery will remember the EORTC 1, 2, 3 trials and what benefit the patients have derived after those trials. So I think I have taken more time than I intended to. Let me introduce you, and very interested in listening to your topic of strategies to improve outcome after esophageal resection. Thank you.
Thank you. So thank you so much for the very kind introduction. And I would once again like to take the opportunity to thank Jimmy and his team for the invitation and for the great hospitality. I've had great days here. The topic I was asked to talk about is very broad, strategies to improve outcomes after esophageal resection. And I will start, let's see if this works now, with the broadest question we have in the field. So what's the overarching goal of cancer treatment? Well, of course, it is to preserve life, both the survival aspect and to preserve the functions so the patient can continue to live a good life. And how do we usually measure this? Let's see if it works here. Well, we do by measuring survival, the quantity of life, and the quality of life. And I think these are the most important outcomes to focus on. Esophagectomy is a big operation, and as you said, we have a lot of complications that we have to try to salvage, and it takes a toll on the patient. So this problem goes for all oncological surgery, but esophagectomy is, a good example of the dilemma of, on one side, going for radicality, trying to take out every potential site of disease, and often combining with quite heavy adjunct therapies. And on the other hand, if we lessen the radicality of the surgery, we have the risk of higher risk of recurrence. So finding this balance is probably what it's all about, if we want to achieve better outcomes from esophagectomy. And I've looked into different aspects, and I will focus on two main topics: best practice surgery and best practice of adjunct therapies. And regarding surgery, I see three main areas. The oncological aspects of the resection is extremely important to achieve long-term good oncological outcomes, of course. And the big debate in esophageal surgery is regarding the extent of lymphadenectomy. The postoperative recovery is, of course, extremely important after this type of surgery. And here we have a big discussion which is very much tilting over to the advantage of minimally invasive techniques versus open. But we also have the introduction of enhanced recovery programs over the last years, which have really improved outcomes. And regarding the long-term quality of life, if the oncological outcomes depend on the resection part of the surgery, the quality of life to a large extent depend on the reconstruction. And we usually use a gastric tube conduit, and it works reasonably well, but it has its drawbacks. And one of the big problems is severe reflux that these patients have to cope with for the rest of their lives. Another big problem is that the conduit, usually we use a narrow gastric tube, and there's a balance between problems with delayed emptying, which affects about 15 to 20% of the patients, and on the other hand, very rapid emptying with dumping problems. And tuning up this balance is one of our big challenges. In the interest of time, I will, however, mostly focus on lymphadenectomy and minimally invasive versus open. Regarding adjunct therapies, I will discuss quite briefly the two main options: chemotherapy alone or neoadjuvant chemoradiotherapy. And the short version is that there is no difference in the trials that we've seen so far regarding long-term survival and long-term outcomes. What I will show you a little bit more of is the first report of our oncological outcomes from a trial that we did between 2015 and 2019, where we addressed the timing of surgery after neoadjuvant cross chemoradiotherapy, comparing conventional surgery before 6 weeks to delayed surgery to 10 to 12 weeks. And this is the first time I'm actually telling anybody about these results. I'm going to report them at the ISD next week. And then, of course, I will briefly go into the revolution of immuno and targeted therapies. So let's talk a little bit about lymphadenectomy. So what defines the ideal lymphadenectomy in esophagectomy for cancer? It's a topic of great debate, and I'm sorry to say we don't have the data to define it as well as we can do for gastric cancer. Gastric cancer has been studied, especially in Japan, for decades, and we now know that a D2 gastrectomy is a very well-balanced lymphadenectomy for locally advanced disease. For esophageal cancer, we have a lot of work to do, and I think the biology of and anatomy of lymph drainage is very different in the esophageal location. And this is a very important paper, published 10 years ago. I think it's been overlooked by most esophageal surgeons. Heike is not here, but she's one of the co-authors. It's from the group at the Cancer Institute Hospital in Ariake. And they looked at the importance of the location, the lateral location of early T1B and T2 tumors with regard to the lymph node metastasis patterns. And Heike was probably the one that could show anatomically that early tumors, non-circumferential tumors located on the left and ventral side, they drain into regional lymph nodes, while exactly the same tumor, but located on the other aspect, on the right and dorsal side, they drain straight into the thoracic duct. And this makes a big difference, because looking at the survival data here, it really had a huge impact for these relatively early tumors. The ones draining to the regional nodes, they have an excellent outcome after esophagectomy, while the ones draining straight to the thoracic duct have a really poor survival for being so early stage tumors. And I have to remind you that all T3, T4s are circumferential, and they all have the drainage pattern of both, meaning that many go straight into the thoracic duct and into the circulation. So this is one of the problems with lymphadenectomy in esophageal cancers. So this is another study from Japan, quite recently published a multi-center study from Yuko Kitagawa. It's a cohort study mapping the patterns of lymph node metastasis in junctional cancers, which is, I mean, very distal. And they included 363 patients of both histologies, and they followed them, they operated them, and they mapped the lymph node metastasis pattern. And this is the outcome overall, which is quite reassuring for those of us doing total gastrectomies. The vast majority of lymph node mets are on the lesser curvature of the stomach and pericardially, and about 10% in the lower mediastinum. So if you can clear the lower mediastinal nodes transhiatally, you're fine. And very few overall with upper mediastinal metastases. You can note that the right recurrent nerve station still has about 5%, and this seems to be a hot station, actually, even from distal tumors. But 5% is not very high. But if you look at the tumors that invaded the esophagus 4 centimeters or more, we have a different picture. It was 10.7% actually involving this 106 Rec-R station, the right recurrent nerve station in the upper mediastinum. And in this image, I have the 5.1 from the overall, but it's 10.7 in this station from junctional tumors going more than 4 centimeters up into the esophagus, which is not very high. I mean, since you have some centimeters in the abdomen, so quite a lot of tumors in the junction and distal esophagus, they metastasize to this station, while the left recurrent nerve station is quite rare. So what about randomized trials? There are not many. There are some going on. This was recently published Chinese trial randomizing between 3-field and 2-field, and this can be defined in different ways, but here 2-field was complete mediastinal dissection, and 3-field included also the neck. And they randomized 400 patients, T1 to T3, and please note N0, N1, no N2s and no N3s. The primary endpoint was overall survival, and there was no difference. So I think we can conclude fairly from this study that it's not indicated to do a cervical dissection in primary tumors below the carina, as in this case, which are clinically N0 or N1. But we don't know about clinical N2, N3, and it didn't address another important issue, whether we should clear the upper mediastinal nodes. I would guess that maybe we should clear the right recurrent nerve nodes, but not the left ones. But we don't know that. So the optimal lymphadenectomy for esophageal cancer is still to be determined. We don't know. We need to do a lot more studies. One of the most important studies going on is the TIGER study, which will collect prospectively thousands of patient data, prospective data on lymph node metastasis pattern, led by Susanne Gisperts in Amsterdam. So let's move on to minimally invasive esophagectomy. There are 2 ways of doing it now, basically. You can do it conventionally or with a robot. I moved on to robot mostly 2 years ago, but both works. There is no evidence for a difference in outcomes, but I think robot will probably take over more and more in the coming years. There are 3 ways of doing it. They're similar to the open techniques, but the new alternative is, of course, hybrid procedures, which is a good way of starting. You can do the abdomen laparoscopically, and you can do an open chest with an open intrathoracic anastomosis during your learning curve, which I think many centers do with good results. There are 3 major or well-designed trials so far comparing open to minimally invasive. The TIME, the MIRO, and the ROBOT trial. The TIME trial was published now 10 years ago. It's quite a small study, only 115 patients. The primary endpoint was lung complications. It included all transthoracic techniques, and the endpoint, the outcome was clear. Primary endpoint, there were less pulmonary infections. The quality of life at 6 weeks was better in the MIE group, and they had equal lymph node yield, equal R0, and all the oncological outcomes were similar. Interestingly, also the quality of life 1 year after was better in the MIE group and mainly driven by less post-thoracotomy pain. The MIRO trial by our deceased friend Christophe Mariette compared hybrid minimally invasive esophagectomy with an laparoscopic abdomen, open chest to open. It was slightly larger. The primary endpoint were complications, Clavien-Dindo 2 to 4. And the results were very similar to the time trial. Complications were 64% in the open group and 36% in the hybrid MIE group. Less pulmonary complications. And very interestingly, and unexpectedly, there was actually a trend towards a survival difference that we haven't been able to explain, but it's food for thought. There was better survival in the hybrid MIE group. Not significant, but very close. And the robot trial, very similar to the time trial, only using robotic instead of conventional MIE. And the findings were very similar, less complications, better functional recovery, and better short-term quality of life. So we have 3 trials very consistently showing less complications, quicker functional recovery, better quality of life in favor of MIE. So this is clear. What about long-term survival? The trials won't help us there. The sample size is not enough. So we can look at registry studies, and we very recently published this study from our Swedish registry. We included all patients with, that underwent Ivor Lewis esophagectomy to make it more homogeneous for cancer. And they were mainly locally advanced T2 to T4A. We used an intention to treat analysis mode comparing open to hybrid to total MIE. 1,404 patients, and the crude, this Kaplan-Meier changed from my computer. It didn't look like that, but the crude data looks like an advantage, and it was even clearer in my computer. But of course, this needs adjustment, and looking at the multivariably adjusted results, there was a significantly better overall survival comparing the 2 MIE groups to the open with a hazard ratio of 0.72. But even more interestingly, the hazard ratio dropped to 0.67 for the total MIE group. So I think there may be something in MIE that benefits the patients long term. I don't know what it is, but I think the fact that they recover quicker, it implies that they may recover their immunocompetency earlier and maybe can, fight the cancer better and delay recurrences, or maybe even avoid some recurrences. We have to look more into the mechanisms. Okay. Now there's a problem. Worked very well until now. Yeah, let's see. No, it's not okay. No. Yes. So just to summarize the surgical part of this presentation, we've come a long way from the Egyptians. Modern surgery started in the 19th century. It didn't happen that much until the 20th century. Open surgery was very much the same. And then we started the digital, minimally invasive revolution in the 80s. And the last stages are increasingly robotic, and we're starting to use AI not only in endoscopy and pathology. There's research going on to use it in surgery, and I'm sure we'll have it in routine surgery in the next decade. So let's move on to adjunct therapies, and I will now show you the data from our trial. The question is, when is the optimal time to operate after neoadjuvant chemoradiotherapy? And after the cross trial, they published observational data. Traditionally, it's been performed 46 weeks after termination of chemoradiotherapy. And from the cross trial, they published observational data showing that tumor regression continued up to 3 months and that the survival was equivalent. And the problem with observational data, especially in this setting, is that the patients that are not operated early, quite often there's a reason, and mainly that the patients can't really tolerate early surgery, so you wait, you let them recover, and so it's a selection of the worst patients in a sense. And so our hypothesis was that prolonged delay of surgery would benefit the patients. Higher complete response rates, better recovered patients would probably lead to less post-op morbidity, and maybe we could even achieve a higher R0 and maybe even better long-term survival by waiting. So, and I didn't think that this question was adequately addressed by the observational studies. So we designed the multi-center RCT, including both histologies, but the primary endpoint was only based on the adenocarcinomas. It was pathological complete response. We gave all the patients cross, and then we randomized them either to be operated within 6 weeks or 10 to 12 weeks after surgery. In the delayed arm, we had extra endoscopy and an extra PET-CT, and at any sign of progression, we operated them, we crossed them over to the early surgery arm. The early results we already published 2 years ago in Annals of Surgery. This is the consort flow diagram. So we screened 400 patients, and we finally included 125 and 124. There was a higher resection rate in the early arm because we had some interval metastases in the delayed arm, which I would think would be to the benefit of the patients not being operated. And interestingly, we didn't see any difference in postoperative morbidity or mortality. It was the same. There was even a small trend towards worse morbidity in the delayed arm. And to the big question, overall survival, I can tell you first that there was no difference in R0. It was about 97% in both arms. And the primary endpoint, complete pathological response for adenocarcinomas, didn't differ statistically. It was 21% in the early arm and 25% in the delayed arm, but not statistically significant. So probably there is a small difference, but it's not of a major difference. But the thing that intrigued us most was the overall survival, because we had expected a slight advantage for delayed surgery, or at least no difference. But what we saw was a quite strong signal of a disadvantage for delayed surgery. And this is squamous and adenocarcinoma together, all 249 patients analyzed intention to treat, with a hazard ratio of 1.35. It's not significant, it's not powered for overall survival, but it doesn't look good in my view. And looking at adenocarcinoma alone, this was even stronger. The difference was smaller for squamous. The hazard ratio is 1.46. Very close to significant. And I think this doesn't prove anything, but it's, to me, it's a strong signal that we should be cautious in delaying surgery, because these patients were assessed for clinical progression, and we didn't find it. So how can we explain the difference? Well, I think part of the explanation is the TRG3s. In the standard arm, they did quite well. They did okay. But in the prolonged wait arm, the TRG3s did a lot worse. So I think the problem is that we can't really find the clinical non-responders, or clinically we can't find the non-responders. It's very, very difficult. And if you delay those, they do really badly. This is probably at least part of the explanation. So let's go to the last topic of my talk, the latest events in targeted and immunotherapy. We all know this. We've seen it many times, but it's very intriguing. I still like showing it. We now have a structure for subgroups, both for squamous cell carcinoma and for adenocarcinoma. I'm not going to go through the subgroups. You all know them. And we're starting to understand the patterns of biomarkers related to the subgroups. The HER2 amplifications are almost only in the chromosomally unstable group. The PD-L1 expression is spread in many groups. Unfortunately, very little in the genomically stable and the diffuse type cancers. And we have good data to show that checkpoint inhibition works with PD-L1 expression and MSI high. And this study, I think most of you know also, it was published more than a year ago. The Checkmate 577, it has the design of patients undergoing neoadjuvant chemoradiotherapy and then esophagectomy. Both histological subtypes were included, and then patients with residual pathological disease, either in the primary tumor or the lymph nodes, were randomized either to nivolumab or placebo for 1 year after surgery. And the results were very clear with a survival advantage irrespective of PD-L1 expression. It was stronger with CPS above 5, but there was an effect even in the patients that don't express PD-L1. And the mode of measuring PD-L1 when the trial was designed was TPS, not CPS, and the CPS analysis were done post hoc. So the trial is the nivolumab is now approved for both squamous and adenocarcinoma, irrespective of PD-L1 expression. And it was also significant disease-free survival advantage for both subtypes separately, which is reassuring. We haven't actually seen the overall survival data yet, and I'm not surprised, but it's not always the case that they approve a drug like this large scale without the overall survival data, but it's actually approved around the world. We have the new ESMO guidelines for esophageal cancer published just online right now, and they include standard therapy recommendations for all palliative lines, both of squamous and adenocarcinoma, using immunotherapy. So we have really broadly now implemented immunotherapy in the treatment of esophageal cancer, both palliatively and in the curative setting. So, is this development the beginning of the end for cancer surgery? So honestly, I hope so. I mean, the ideal would be to cure patients without any disruptive major surgery. But because what we see is systemic cases becoming oligometastatic and even locoregional. We had several cases in the last couple of years of patients with massive disseminated disease, and after HER2, anti-HER2 therapy or immunotherapy, they just had the primary tumor left, and we've operated a few of them. And in the long run, they might be cured. But I think in the short term, we're going to see more surgery, because about 60% of our patients don't go to surgery because they're too frail or they have too advanced disease. And I think many of the ones with advanced disease that can tolerate surgery in the next few years will go to surgery. And I think the chance of curing with systemic therapies, we're not really there yet. But I hope we'll get there. So to summarize, best practice surgery, we don't know what the optimal best practice lymphadenectomy is yet. We need to study this more. I think I can quite safely say that minimally invasive esophagectomy should now be standard of care. And we have the ongoing evolution of refined robotics and AIs coming in, and I'm quite convinced that this will improve the outcomes of esophagectomy in the coming decades. And regarding adjunct therapies, I think we should probably be careful in delaying surgery too much after neoadjuvant chemoradiotherapy. And we have the revolution of targeted therapies and immunotherapy going on, and we've just seen the beginning. Thank you very much.
Thank you, Professor Nilsson. We started a bit late, so we do have a few minutes for questions, yeah? Okay. So first of all, thank you very much. That was an excellent talk. It's not my field, but I still have a question for you later on. But maybe I'll open it to the house first. Anybody who wants to? Yes, please.
Morning. Can you hear me? Morning, Magnus. Thank you for a wonderful talk. Two questions, and you probably know the answer already. One of the big things that we notice about is you correctly mentioned that minimally invasive surgery will be the standard care in the future for esophagectomy. However, the big thing is how do we get there for the next generation or for the future generations? Because it's so hard to train. You need volumes, you need centralization, etc. And after the time trial, the outcomes from the Dutch registry has showed a significant rise in complications and morbidity and mortality and leak rates with the introduction of minimally invasive esophagectomy. How do we try to prevent that for different countries, or how do we learn from the Dutch experience? And the second question, if
can we take one at a time?
no problem. Thank you very much for this.
Question.
Thank you.
Yeah. Well, training, I think, is not so different from open surgery. I think it's even easier to train fellows in minimally invasive surgery. We have double consoles for the robot. We have, we operate together with them laparoscopically. So I think it's about the volumes and centralization mostly. Regarding the learning curve, the poor outcomes in the beginning, this was during the learning curve. And in our Swedish study with better overall survival, we had all the learning curve of all the centers. And the overall survival was still better. And we also published in the same paper, I didn't show you the complication rates, and they were a little bit better after minimally invasive, but not that much better. The leak rates were slightly higher after minimally invasive technique, but the medical complications were less. The pulmonary infections and the cardiovascular affections and so on were less. And still they have a quicker recovery, because it's not the patients that have the complications that are probably the difference, it's all the other patients without complications that probably do so much better from minimally invasive techniques. So I think we have a challenge during the learning curve, and we have to have proctoring programs, and we have to have very structured teaching programs. But I think we're not going to have the same problem in the future, because now most centers have already learned, and there are experienced minimally invasive surgeons throughout, and they can train their trainees. The problem was when all the centers started up and everybody was inexperienced. That's when we saw mostly the bad short-term outcomes. And despite that, we had good long-term outcomes for the whole group. So I think we're going to see even better long-term outcomes in the future when we have more experienced teams doing this.
Thank you. My second question is, often when we use neoadjuvant therapy before esophagectomies, the patients, depending on different units and different countries, get almost one-size-fits-all kind of neoadjuvant therapy. And as we grow up over the last 8 years, we've seen so many changes. We've also realized that radiation therapy is not required in a lot of cases, whereas where radiation therapy only gives you local regional treatment, which very good surgery can do. And we think that systemic therapy is even more important for long-term overall survival for these patients. What are your comments about this?
Yeah, I also actually think that the ideal, probably, we don't know, but is very good systemic therapy with radical surgery. And I think radical surgery and radiotherapy have the same objective of local control, and we probably don't need radiotherapy for most cases. I think we could probably reserve it for some cases where we need downstaging or we have a very advanced local disease situation. But so tailoring it that way would be good. We don't really have the data to do that. We do it maybe from a clinical sense or feeling more today, but we hope to have more data to guide us in the future. And I think these trials, the NEO-AEGIS and the ISOPEC, when we pool them, we will be able to look at subgroups and maybe have data to guide us in tailoring the neoadjuvant and perioperative therapy better in the future.
Thank you very much once again, Magnus. Thank you.
Can I just ask those audiences on Zoom? I don't see any questions on put here, but while Professor Macker is making the next query, can if any of you have questions, please put it online. Yes, please.
Magnus, a very intriguing and fantastic talk. I really enjoyed it. And I appreciate that you shared the recent results of the trial that are hot off the press. One very interesting thing in the Kaplan-Meier that you shared with us was that the difference in survival was not evident until after it looked about 12 to 13 months. All the curves, meaning the early surgery and the delayed surgery groups, completely overlapped, and then they diverged.
Yeah.
So the difference is probably not going to have anything to do with the surgery itself. It's something deeper. Can you speculate what that is?
Well, I mean, what I think is that what we see from the data is that the TRG3s were really at a loss from the delayed surgery, and that those 6 weeks difference actually made a difference for quite many patients in the disease actually progressing and spreading. We haven't analyzed yet the patterns of, or we're doing it now, the patterns of recurrence and so on. Right. That will be very interesting. But I think, I mean, it's definitely the delay that causes the difference, and it must be, in my mind, that there is some progression during this time interval in the delayed group.
Thank you.
Thank you. I think we are 10 minutes overshot, but I think we started a bit late, so I think I'll keep my question to you for later, maybe during coffee time.
Thank you very much.
I don't want to show my ignorance. So I think just let me thank you for this wonderful talk.
Thank you.
And pass the dais on to the next chairman.